Dr. Warner.
Hey.
I've got a patient with a swollen wrist, but I'm not sure if it's soft tissue swelling or an effusion. Can we take a look at it with ultrasound?
That is a great idea. And if it's an effusion, you can tap it with the ultrasound.
First, we need to find out if the wrist is swollen because of an effusion or if it's just soft tissue swelling. We're going to look at the dorsal aspect of the wrist with the wrist in neutral position and slight ulnar deviation. Since we are examining a superficial structure, we'll use the linear high-frequency ultrasound transducer. If you have a high-frequency hockey stick transducer, you may want to use this for pediatric or smaller joints. You'll want to use a preset that optimizes superficial structures on your ultrasound. A musculoskeletal, superficial, or small parts setting will do. We have a wrist preset on our machine that we're going to use. Wrist arthrocentesis is usually done using anatomical landmarks. We'll show you the landmarks and then we'll demonstrate how ultrasound can help us see those landmarks, especially in larger patients. Aspiration is performed between the radius and the lunate bone. To find the joint space, follow the extensor pollicis longus tendon back to the wrist. Just medial to the ulnar, you can palpate Lister's tubercle on the distal radius. And just distal to that is the joint space. Flexion of the wrists helps to identify the space by making the lunate more prominent. Easy enough in a thin patient, but what if there's a lot of adipose tissue, or the wrist is so swollen and tender that you can't find those landmarks? Ah, yes, that's why we're going to use ultrasound. Eli is applying a thick gel cushion to the dorsal aspect of the wrist. We're going to look at the wrist in the sagittal plane. In this view, the transducer is placed with the indicator towards the patient's elbow. On the screen, the indicator marker corresponds to the transducer indicator. So the patient's elbow is to the left side of the screen and the fingers are to the right. The optimal place to look for and tap an effusion is just to the ulnar aspect of the extensor pollicis longus tendon. The ultrasound of this view shows the distal radius and the lunate bone. When an effusion is present, an anechoic or hypoechoic area will be seen pushing out of the joint space. Arthrocentesis is a sterile procedure, so we have prepped and draped the wrist. Our syringe and needle are on the sterile field. In addition, the ultrasound transducer has been covered in a sterile transducer cover and we're using sterile gel. Please see the Access EM procedural video on ultrasound-guided internal jugular vein cannulation for a demonstration of how to apply a sterile probe cover to the transducer. Our ultrasound machine is placed just to the patient's left so that Eli can see the screen with minimal head movement. The skin over the arthrocentesis site has been anesthetized and we are ready to proceed. The transducer is held by the left hand in the sagittal plane. The center of the long face of the transducer is placed directly over the middle of the joint space. A 19 or 20 gauge needle attached to a syringe will be inserted at the center of the long face of the transducer, angled just slightly towards the transducer. Placing the joint space in the center of the screen and then placing the needle at the center of the transducer is key to successful needle placement in the joint space. Insert the needle right next to the middle of the transducer. The hyperechoic needle tip is visualized in the center of the screen as it enters the joint space. Once the needle tip is visualized, gently draw back and voila! Joint aspiration is complete. Identification of joint effusions and joint aspiration are easy with ultrasound. The keys to success are preparation, proper positioning of the joint, and accurate alignment of the transducer with the needle. So next time you have a patient with a swollen wrist, take a look with ultrasound.